And here I am to talk to you particularly today about our experience during the pandemic and just in general with a lens on social determinants of health, health-related social needs, because that's the focus of our team. But I'll tell you a little bit also about the overall enterprise approach to our members as we serve during the pandemic as well. So I'll start out just telling you a little bit again about what our bold goal team is, just because that and our population health strategy is a little bit different from population health strategy and more clinically focused organizations. I'll tell you a little bit about what we do in terms of how we focus on health-related quality of life and social determinants of health, which really have a very patient-centered focus, right? These are self-reported measures, so we do have a strong focus on patient-reported outcomes. And then I'll kind of hit some of the highlights for how we've responded in the past year. A year and a half now. Gosh, I mean, we've all been working from home since mid-March, and probably aren't going to be heading back until this fall. So our bold goal is a team, population health strategy team that is situated in our Chief Medical Officer's organization at Humana. It's the Office of Health Affairs and Advocacy. And really, our mission, our work is about improving the health of the people we serve and the communities we serve by making it easier, knocking out some of those barriers to achieving best health. And, when I say communities, we do a lot of work in specific geographic communities, as well as when I think about communities or population segments as well. So I won't go through every detail here, but just kind of giving you a timeline for how we've been doing this work. It started about 7 years ago in San Antonio, where we were looking at ways to collaborate across communities and bring together organizations across sectors to, public, nonprofit, for-profit, who are coming at health, different kinds of organizations, hospital health systems, local government, providers, nonprofit organizations that may be doing food delivery or housing, health in all policies kind of approach. And we chose initially, because we are going across communities, we chose health-related quality of life, the CDC's Healthy Days measure, as the way we're going to demonstrate how we're improving health. Now, we've evolved along the way and folded in health-related social needs and social determinants of health, because those are strongly related to health-related quality of life and to clinical outcomes. We do a lot of this work through partnerships at the local, state, and national level, and with provider communities. And we partner with universities, and we've expanded to different lines of business. We focus on Medicaid membership and Medicare primarily. We've scaled up our screening of social needs, and we're actually testing out how do we address these needs and through our benefits on plans to be able to address things like providing food so that people can take their medicine as prescribed with food, not take it on an empty stomach. So, and we're even evolving in this past year to this community of opportunity work where we're folding in health equity to this work as well. It's been on our radar for a long time, but of course this past year really brought long-time structural and systemic inequities to the forefront, and especially in our hometown in Louisville, Kentucky. So let me tell you a little bit about what we do in terms of our self-reported, patient-reported, patient-centric measures. We use the Healthy Days measure, as I mentioned before. Some of you may be familiar with this. It's used commonly in public health departments across the country in their annual BRIFIS, Behavioral Risk Factor Surveillance System Survey. We also use it at Humana, and we survey hundreds of thousands of our members every year as a population pulse to see, to compare year over year within communities. We also use it, in pilots and interventions as a leading indicator. But basically, we're asking people, in general, how their health is. Is it excellent, very good, good, fair, poor? We're asking them in the past 30 days, how was their physical health? How many of those days were not healthy days, physically speaking? How many of those days in the last 30 were not mentally healthy days? And we're not talking necessarily mental illness, but stress and emotional challenges. How many of those days were not good? And we also ask about functional limitations. But we do a lot of focus on the middle two questions: the physically healthy days or unhealthy days, and the mentally healthy days or unhealthy days. And as you can imagine, not only in our membership, but across the country, the mentally unhealthy days and stress has gone up for everybody, across the country. We do report every year in an annual progress report what we see and observe in our own membership, but often it will be mirrored in other public reporting measures of well-being. One really interesting thing that we've learned along the way over the past few years, and it's not surprising. I mean, people are really good judges of their health, right? If you ask someone how they feel, it often corresponds with clinical health, right? So when you look at someone with a condition like diabetes, chronic condition, COPD, I mean, they're not all on here, but, heart failure, anything like that, you're going to have poor health-related quality of life. And, the older you are, likely you're going to have more health problems, right? We know that disease prevalence increases and so forth. Group when you see on the far left here, group means more a younger, traditionally commercial kind of plan membership. So those are a lot of younger, healthier working age people. They have on average, fairly low number of unhealthy days each month. I mean, everyone has some stress, right? But it's a lot lower on average than you would see in a Medicaid population with a lot of needs or an older Medicare population. But what's really striking about this is you see food insecurity and loneliness called out here as social needs or social determinants of health that have a huge burden on health-related quality of life. When someone is food insecure or severely lonely, their health-related quality of life is poorer than someone who doesn't or who has depression. Now, these are not mutually exclusive categories here on the bottom, but to me, it still speaks to the burden on health-related quality of life that is present with these social needs. And you could have diseases going on at the same time, but to me, it's an additive compounding thing that makes things worse on clinical health. We also see that those social needs, not only in our own data, but in the literature, correspond with a whole host of poor clinical outcomes. I mean, I don't think I have it all in the deck here, but I can tell you that when you're lonely, you are several times more likely to be readmitted to the hospital in a year. You're several times more likely to develop dementia. When you're food insecure, there's a strong relationship between medication adherence, between blood sugar, A1C control. So all of these things have a huge tie and burden on your clinical outcomes as well as your health-related quality of life. And we've done some large-scale surveying too with our members to understand how prevalent these needs are in populations and how they co-occur at the same time. So just like disease, health-related social needs can be complex and comorbid. So this is, the green is our Medicare member population representative of them. We surveyed several 100,000 of our members. It's a very, very representative, generalizable population to our overall Medicare population of a few million members. And we see that the prevalence, so 52% of our members have at least one social need. The top one is financial strain, and that's not just low income. That's, people could be above an income threshold that qualifies them for some subsidy programs, but still have trouble affording some of the basics, in terms of rent or having enough money for their groceries or transportation or other necessities, utilities, right? Or medication. Food insecurity, loneliness are other top ones. Actually, loneliness is the second most prevalent social need we see in our senior population. We also see it as very common in our, we have most of our Medicaid membership is in Florida. We do have some Kentucky Medicaid membership, and we've just surveyed them. And we also see that loneliness is very high among that population, which is traditionally a younger population, right? You don't see the results here, but we also followed a cohort of people over the year, and we did see that loneliness increased over the year, which among our own membership, among our senior population, and among our Medicaid population. And that was mirrored in the nation as a whole, right? We've all seen those surveys out there. We've seen reporting on loneliness increasing. Now, one of the things that we didn't see increase in our population, and I'll tell you a little bit about that during COVID, is we actually saw that we were able to stave off, increasing food insecurity and some other basic needs because we were proactively reaching out and trying to address that with several solutions. But I just wanted to give you a flavor here to see how prevalent some of these social needs and challenges are. And we also on the back end, of course, are looking at how the combinations of these needs or multiple needs or individual needs relate to a whole host of poor clinical outcomes and why it's so important for us to address these. And here's just another example of social needs. And this across the bottom, you'll see is the increasing number of comorbid, co-present social needs. And you can see that the cost of care, which is that light green number, increases with the number of needs that someone has. And you can also see that this is a look at A1C, HbA1c control, and you can see that compliance or control of blood sugar decreases with the number of those social needs. And we see this with a host of other disease measures, but I mean, it's not surprising, right? It's intuitive, but we're able to see this in our own data. So just wanted to, we serve a lot of people with a lot of different conditions and who have, all these chronic conditions make people much more susceptible to this time during COVID as well. So I'm trying to tie all the threads here together. But I wanted to help you understand why we are so focused on these social needs and their ties with health outcomes. So let me talk for a few minutes about what's been happening at Humana over the past year or so in terms of how do we make health easier and try to keep people well during this global pandemic. So we did a lot of things across the organization. Social determinants of health was a big part of that, right? I've mentioned that. Of course, we were also doing things to make testing for COVID affordable, accessible, removing copays, anything like that, removing that cost burden for testing and for COVID-related charges. We were working on getting telehealth access set up for members, right? And doing things in the home as much as we could, whether through telehealth or through safer home visits. We also worked to do anything we could to help our providers and members in terms of affordability. We fast-tracked a lot of things around I think we had something like 4,000 telehealth visits for January and February, and then scaled that up, March through May last year to about 10 times that amount, what we were normally seeing. So we rapidly scaled that work up in terms of getting that kind of access for people. Now, we also worked to, as I said, to waive a lot of those out-of-pocket costs, and we did other things like allowing early prescription refills for people so they didn't have the burden of trying to get out to places or they could get them delivered to them, and make fewer trips out. On the provider side, we were trying to make it easier and get rid of some of those authorizations burdens that happened to delay care. and expedite some bonuses for them to help them get their work done and improve quality. And we took some of the administrative burden off them as well. Now, we really wanted to assess both medical and social needs, and we have home-based teams and telephonic-based care teams that are reaching out to our members, whether via telehealth or telephone or actually being able to go to their home. And we have a basic needs program that we really set up and scaled up in this past year, where care managers, clinicians, were reaching out to members and asking them about all those needs I mentioned. Were they able to get their prescriptions? Did they need to see a doctor? Did they need safe access to a doctor? But also, did they have some needs about, did they have needs for food or other kinds of strains on them in their home that may have been getting in the way of their best health? We were screening them for food insecurity, screening them for loneliness and isolation, and other needs, and trying to not only screen them and ask them, but address that. We began, making sure they had enough medication on hand. We set up emergency meal deliveries. We started doing some extra benefits tests for people so that we could connect them to either healthy food benefits or that we could offer, or through resources in a community. We were able to provide shelf-stable meals for people who had storage ability. We were fielding thousands of requests a day for food and other assistance, and really trying to scale that up. I can tell you a little bit more about that, but we've served well over 1 million meals, and those were numbers through, I think, early Q1, and we continue to do some of that outreach. Let me tell you a few more of our initiatives that we've been working on during this time that really pertain particularly to these social needs. And PAPA is a program that some of you may have heard of. PAPA Pals is this social entrepreneurial group that is kind of like companionship on demand, and it pairs trained college-age, typically students, to be companions to seniors. They can help out with non-clinical types of things like delivering their groceries or helping them set up their iPads so that they can communicate with family members across the country. Go play chess with them, change a light bulb, whatever, but providing that kind of companionship. Now, one of the things we did during COVID was to offer that virtually as well as the in-home visits, so people felt safe but still had a connection. We started a friendship telephonic line to connect with people, and we were getting inbound calls from people who were lonely, so they had someone to connect with. We worked with a whole consortium of organizations to start this Far From Alone campaign, to reach out to people and let them know that they had some connections to others, and that they were not alone in feeling lonely and isolated. And of course, I did mention our basic needs efforts around the food insecurity work. And then, we just worked on expanding platforms and technology to connect people to other resources immediately in their communities. So again, we're still getting through this COVID time as a health plan and trying to help people. And we know that there are some new normals, and it's hard that are going to be emerging. It's sort of hard to really envision what that new normal will be. But, we know that data are going to be very core to it, an ability to collect more data, stratify it, and understand needs better, to partner together cross-sectorally. We have to think about our payment models to support this kind of work. And we know that health inequity has to be a part of the solution to expand access to coverage and resources for especially vulnerable and marginalized populations. And we are seeing that right now in the data that we're collecting through surveys and trying to act on. So I just wanted to, again, just give you a quick overview of the things that we've been thinking about from a plan perspective, and because we do deal with a lot of older, sicker, vulnerable populations. So thank you.
Thank you so much for sharing that. It was really interesting to see that data too and know how you're tracking that. That's very cool.
Sure. Yeah, and if anyone's interested, you can always go to our population health website here to see some of our reporting and our resources around social needs.